whose information his mother and information was reliable. He presented with the complaints of abnormal movements. Abnormal movements in the form of sudden forward movement of both the neck and upper and lower limbs in clusters in 10 days prior to admission. Each of them lasted for approximately 5 seconds and 2 to 3 times per day. And the number of such episodes increased in frequency and duration as the days progressed, and hence was brought here for further management and evaluation. There was no history of posturing or jerky movements of limbs or rolling of eyes, no history of drowsiness or loss of consciousness, no history of deficit in eye movement or abnormal eye movements, no history of difficulty in swallowing, sucking, or nasal regurgitation of feed, no history of excessive drooling of saliva or deviation of angle of mouth to one side. There is no history of association of these movements with sleep. No history of excessive crying before the episodes of bluish discoloration of skin and mucous membrane. No history of unusual order of body or urine. No history of abnormal hair color. No history of reduced oral intake. No history of fever. No history of vomiting, loose stools. No history of cough or fast breathing. No history of excessive sweating of forehead or sucrose cycle while feeding. No history of any recent vaccination. Coming to the past history, this child had an episode of severe bronchopneumonia requiring PSU admission at our hospital at the age of 4 months, needing HFC support.
Can you go slower, please, Anita? Don't be so fast. Can you go slower, please?
Okay, sir. And echo done at that time revealed small osteoprimum AST. Coming to the antenatal, natal, and postnatal history, this child was a spontaneous conception at the age of 28 years, who is a firstborn of non-consanguineous marriage. The antenatal period was uneventful and antenatal scans were normal. Child was born at a term by normal vaginal delivery with a birth weight of 2.8 kg, length 50 cm, and head circumference 34 cm. Child was said to have cried soon after birth. There was no history of hypoglycemia or seizures. Child had a history of neonatal hyperbilirubinemia and phototherapy was given for 1 day. Child had no blood group incompatibility. Postnatal period was also uneventful and baby was feeding well and got discharged on day 4 of life. Coming to the developmental history, the gross motor, baby had attained partial head control and said to have attempted rollover by 4 months. Fine motor, there were no hand regard was observed. Social, there were no social smell till presentation to us. And child was able to make cooing sound. In vision and hearing, child was not following light or was not responding to normal sound by the age of 5 months. And later, parents noticed that the child had lost the ability to hold his head steadily. Coming to the dietary history.
So can you just kind of just tell us, Anita, what are the things that you have found as positive and what are the things that are extremely importantly negative in this? Just stopping you here and just kind of summarize what you.
It was found to have a regression of milestones with the global with the developmental delay in all 4 domains of development.
So you're saying that this child was born to a non-consanguineous parentage?
Born out of non-consanguineous marriage.
And then this child is a first child or is it a mother who's
first child of non-consanguineous marriage?
Non-consanguineous marriage is the first-born child, and there is no history of an antenatal problem that was there in the mother. And why did you talk about fetal movements and all that?
Sir?
You said something about fetal movements?
Sir,
did you say something about fetal movements? Did
sir,
you say something about fetal movements, antenatal period?
A normal antenatal period was uneventful, sir.
Was normal. Oh, okay.
Right.
Okay, please go ahead.
Coming to the dietary history, child was on exclusive breastfeed. Immunization history, BCG scar was there. There was no history of adverse event following immunization. Child had last vaccine at 3.5 months and followed a national immunization schedule. Coming to the family history, there was no family history of any seizures or developmental delay, no history of any sudden death in family. Coming to the socioeconomic history, they belonged to upper middle class as per the modified Kukusami scale 2018. They had a puka house, there were no pets at home. For summary from the history, this 5-month-old child who is the firstborn of non-consanguineous marriage with the uneventful antenatal postnatal period, except for neonatal hyperbilirubinemia, immunized up to age, presented with the recurrent spasms in 10 days and was noted to have regression of milestones.
What are the other things that you would like to ask in history that may suggest? I mean, if we with this diagnosis, what are the differential diagnoses that with these presenting complaints? What are the differential diagnoses you kept at, Anita?
Neurodegenerative diseases.
Why did you think in terms of a neurodegenerative disease?
Regression of milestones.
Regression of milestones. Okay.
Then seizures were there. Spasms.
Spasms were there.
Then inborn errors of metabolism.
Right. Okay.
There can be some structural brain abnormality.
Right. Okay.
Sir?
Fine. Okay.
Shall I proceed, sir?
Yeah, please go ahead. Please go ahead.
Coming to a general examination, the child was alert and ephemeral, was in supine position. Temperature was 98 degrees Fahrenheit in the right axilla. His pulse rate was 112 per minute, normal volume. His peripheries were warm, all peripheral pulses were felt equally. And the respiratory rate was 45 per minute, abdominal thoracic. Saturation was 99% at room air, and blood pressure was 90 per 60 mm Hg. Coming to the head to foot examination. His head was normal in size and shape with the wide open AF. Hair was normal in color. Face had a prominent forehead and bitemporal hollowing. Eyes were normal. Nose was found to be short with upturned nares, and mouth, child thick upper lip and long filter. Ears were low set.
So there was some dysmorphology that was associated.
Facial dysmorphism was there. And sir?
Please go ahead.
In skin, there were no neurocutaneous markers noted, had no neck swelling, chest and limbs were normal, no evidence of any contractures or skeletal anomalies. Child normal male external genitalia, bilateral testis descended, no pallor, ictus, cyanosis clubbing, or lymphadenopathy. This was the facial dysmorphism now clearly appreciated from this picture. Coming to the anthropometry, the child had a weight of 5.6 kg against an expected of 7.4 kg, lying between -2 and -3 standard deviation. His length was 59.5 centimeter against an expected of 66 centimeter, which was at -3 standard deviation and below third centile. And his head circumference was 41 centimeter against an expected of 42.5 centimeter, which was between -1 and -2 standard deviation. Plotting of the weight, height, and head circumference in the WHO chart. Coming to the developmental assessment, on 180 degree.
Height and non height and non
length. On 180 degree examination in supine position, child was lying with the flexed upper limb and lower limb. On pull to sit, child had complete head lag. On sitting posture, child his back was rounded. But in suspension, the child was power, there was no scissoring. On mental suspension, child momentarily holds head in horizontal plane, and in prone position also lifts head momentarily. Coming to vision, child does not follow objects or light, no fixation of object. Hearing, child was found to have reduced response to normal sound. Our started response was there. In gross motor, child was found to have development quotient of 40% as he did not attain head control. And in fine motor, 14%, 40% in social domain, also 40%, and personal and language domain, he had a developmental quotient of 60%. Coming to the systemic examination,
can you just summarize again? Can you just summarize what the development is and till far whatever the examination is? What did you do from this particular patient, from looking at the patient and initial assessment?
A 5-month-old boy who presented with recurrent flexion of neck and limbs for the past 10 days with the on examination was found to have global developmental delay, which was confirmed with the 180-degree examination. And in vision and hearing, child is not following object and it was reduced response to sound.
So when you're looking at the baby's assessment, are you saying that the baby is normal tone or hypotonic or increased tone?
Sir, examination was suggestive of hypotonia, sir.
Okay, so from the posture, did you make or did you say anything based on the posture? What was the posture of the baby? What was the kind of way the head was moving? Was his limbs moving spontaneously? Was there anything in that was characteristic?
For this baby, sir, the baby was lying on supine position, was with the flexed upper limb and lower limb, sir. If it was completely hypotonic, was this asked about this baby or generally about hypotonia, sir?
I'm just asking about this particular baby. What was the description of the spontaneous movements? What was the general position of the limbs?
This baby's limbs were flexed, sir, but on examination, I had a complete head lag and complete head lag and it was suggestive of hypotonia. And on sitting also, his back was rounded. There was no much spontaneous movements of limbs.
There was not much of a spontaneous movement of limbs. So the baby was lying hypotonic. Was there any characteristic posture that you would like to describe?
No much spontaneous movements.
Any particular posture that you would like to describe the baby was in?
The third frog appearance.
Sorry, I didn't hear you.
You're riding pictures, sir?
No, was there any? What was the kind of movements that were there? No spontaneous movements, some spontaneous movements. Was there any?
Some spontaneous movements were there, sir, not complete hypotonia, but some spontaneous movements. I was lying supine with the upper limb and lower limb flexed.
Okay. Okay. Please go on to the systemic examination.
Shall I proceed, sir?
Yeah, please.
Coming to the systemic examination, hair mental function, child was alert. In cranial nerve, first was not examined. Second, Menis reflex was there. Child was not fixing object. Fundus was normal. 3, 4, 6, he was not following object. Fifth nerve, there was no deviation of jaw. Seventh nerve, complete eye closure was present. No facial asymmetry. 8th nerve, child responds to loud sound. 9th and 10th nerve, was present. Uvula center, bilateral palatal movements equal. 11th nerve turns head to both sides. 12th nerve, there was no deviation of tongue, no tongue fasciculations. In motor system, child posture was supine and upper limbs flexed and lower limbs extended. But was equal on both sides. And don't there was mild hypotony in all four limbs. His power was more than 3/5 in all four limbs. Coming to the reflexes, in superficial reflex, abdominal reflex was normal. Deep reflexes were also not exaggerated or absent. Biceps was deep reflex was also normal. He was found to have persistence of primitive reflex at the age of 5 months. Grasp reflex, moro-glabellar, sucking reflex and rooting reflex was present. Palm movement reflex was absent. Sensory system examination was not done. Cerebellar system, there was in the cerebellum, there was no signs of nystagmus or no titubation. Skull and spine head appeared normal in size and shape. Air was wide open, not bulging, no overriding of sutures. Spine was normal. In other systems, per-abdomen examination, other systems were no significant finding was there. So abdomen was soft, no organomegaly. Cardiovascular system, precordium was normal, no cardiomegaly. S1, S2 heard, no added murmur. Respiratory system also, child had no tachypnea, bilateral errantly equal, no added sounds. Coming to the summary. 5-month-old boy, firstborn of non-consanguineous marriage with the normal antenatal, natal, postnatal period and global development delay and regression of milestone with no significant family history. Immunized up to age was brought with the history of recurrent spasms in 10 days. On examination, child had a facial dysmorphism, poor fixation of a object or light and was found to have increased startle response with a mild hypotony in all four limbs. Complete head lag on developmental assessment with and persistence of primitive reflexes.
So based on your history, you feel that there's a regression of milestones rather than a child who has been slow in achieving milestones. Yeah, that is only based on the history that you got. You haven't got a evaluation before the child presented to you, so you don't really know whether there's any development milestones that were documented to be known.
Regression is only in the history also. So shall I proceed?
Yes, historically, if you're thinking in terms of regression, your possibilities narrow down quite a bit, right?
His findings were more suggestive of a neurodegenerative diseases. Or more of a gray matter disease. Or it may be due to any structural brain abnormality or any epileptic encephalopathies.
Oh, please go ahead.
At this point, the differential diagnosis considered there include neurodegenerative diseases, structural brain abnormality, epileptic encephalopathy, any genetic syndromes, inborn errors of metabolism or CNS infections.
So there is no fever in this child.
No history of fevers and infections were less likely.
And there is no history of trauma that you could.
No, sir. Investigations ran were within normal limit. When we did MRI brain for this child, which showed partial hypoplastic sulci with pachygyria and smooth cortical surface of supratentorial brain parenchyma, features suggestive of Neuronal migration defect lysencephaly. This was the MRI picture of this child. And when we proceeded with the EEG, there was hips arrhythmia. In view of reduced response to sound is buried and was normal. We also said in view of this spatial dysmorphism, genetic testing was done. Whole exome sequencing done showed features suggestive microdeletion at chromosome 17p, suggestive of Miller-Dieker lysencephaly syndrome.
So what were the morphological features that fitted into that diagnosis?
So child had bitemporal
hollowing,
prominent forehead, long filter was there, upturned nails were there, low set ears.
So you made a diagnosis possibly from the physical characteristics that there's a possibility of a central nervous system issue, and possibly you may pick it up in the MRI that's been done. Okay, thank you.
His diagnosis was global developmental delay, Miller-Dieker lysencephaly syndrome, symptomatic West syndrome, and synovial heart disease, ASD. This child was started on considering the possibility of West syndrome. This child was started on ACTH, 150 units per meter square per day intramuscularly, and physiotherapy was also started. From after the initial 2 doses itself, his spasms were stopped, and close monitoring of his electrolytes, blood pressure, and sugars were done. After the initiation of ACTH treatment, this child was noted to have raised the blood pressure, and in view of this, he was started on ifedipine along with ACTH, and ACTH was stopped on day 17 of admission, and vigabatrin was started. Then after, repeat EEG taken after completion of ACTH showed focal epileptiform activities arising from bilateral anterior temporal lesions. The child was discharged on day 19 of admission on vigabatrin and neurodevelopmental therapy. Present status of the child is now 9 months old, undergoing developmental therapy, still has global developmental delay, no recurrence of spasms. Shall I proceed with the topic discussion?
Your diagnosis is clear from the MRI picture, and from what you're saying is the physical findings that were there.
So child had spasms, and in your primary diagnosis was symptomatic West syndrome, sir. In view of the facial dysmorphism, we proceeded with the genetic testing and was found to have Miller-Dieker lysencephaly syndrome. Shall I proceed?
Please do.
Coming to the topic discussion, lysencephaly or agiria is a rare disorder that is characterized by the absence of cerebral convolutions and a poorly formed sylvian fissure, giving the appearance of a 3 to 4 month old fetal brain. The condition is probably a result of faulty neuroblast migration during the early embryonic life, and is usually associated with the enlarged lateral ventricle and heterotopias in the white matter. In some forms, there will be a 4-layered cortex rather than a usual 6-layered one, with a thin rim of periventricular white matter and numerous gray heterotopias visible by microscopic examination. Milder forms of lysencephaly also exist. This is a picture showing lysencephaly with a smooth appearance of the brain, and the sylvian fissure is not too deep. enlarged ventricles also. Children will present with the features of failure to thrive, microcephaly, marked developmental delay, severe seizure disorder. They may also have associated ocular abnormalities like hypoplasia of optic nerve and microphthalmia. Coming to the Miller-Dieker syndrome, which is a rare genetic disorder, autosomal dominant inheritance. Gene LIS1 in the chromosome region 17p is deleted. It is associated with the characteristic features like prominent forehead, bitemporal hollowing, anteverted nostrils, prominent upper lip, and micrognathia. Child may also have microcephaly, seizures, cardiac malformation, and growth restriction. Other CNS anomalies include ventriculomegaly and absent or hypoplastic corpus callosum. CT and MRI will be showing smooth brain with the absence of sulci. Into West syndrome, it is a neurodegenerative disease with the usual presentation between 2 to 12 months, having a triad of infantile epileptic spasms, developmental regression, and hypertrophy on EEG. It's a picture showing hypsarrhythmia, which are high voltage, slow cavity background with the multifocal spikes. Different types of West syndrome include cryptogenic and symptomatic. Cryptogenic, which is also known as idiopathic, now referred to as unknown etiology, have normal development before the onset. However, those children with the symptomatic West syndrome will have preceding developmental delay owing to either perinatal encephalopathies, malformation, or underlying metabolic disorders or other etiologies. In males, West syndrome can also be caused by ARX gene mutation, often associated with ambiguous genitalia and cortical migration abnormalities. West syndrome, especially in case of unknown etiology, is a medical emergency because a delay in diagnosis of 3 weeks or longer can affect the long-term prognosis. Coming to the treatment, West syndrome is best treated with the hormonal therapy in the form of either ACTH injection or oral steroids. There are several protocols that range in dose from high to intermediate to low. The recommended regimen for ACTH is a daily dose of 150 units per meter square, administered over a period of 2 weeks and gradually tapered over a period of 2 weeks in 30, 15, and 10. Response is usually observed within the first 7 days. During the tapering period of any regimen, spasm can relapse. And in such cases, the remediation entails increasing the dose to previously effective dose of food for another 2 weeks and then again tapering. Synthetic ACTH like tetracostatide and procentropin can also be used as long-acting preparation is chosen. Oral high-dose prednisone is a lower-cost alternative, but it may be inferior in efficacy to ACTH, particularly in those with cryptogenic West syndrome. Awake and sleep EEG are often done at 1, 2, and 4 weeks after the initiation of hormonal therapy to monitor the patient's response with the aim of EEG clearing from hypsarrhythmia and stopping of seizures. The side effects include hypertension, electrolyte imbalance, hyperglycemia, or glycosuria and gastric ulcers. Hence, close monitoring of blood pressure, electrolytes, and sugars are important. Prophylactic therapy for ulcers with H2 blockers or proton inhibitors is also desirable. Dual treatment with the vigabatrin and hormonal therapy at the onset of spasm may be superior to hormonal therapy alone. Subsequent alternative treatment options for spasms include valproate, benzodiazepines such as nitrazepam and clonazepam, topiramate, lamotrigine, zonisamide, pyridoxine, and intravenous immunoglobulin. They are useful for decreasing the frequency and severity of seizures in patients with symptomatic infantile spasm and also as an adjunct therapy in patients with idiopathic infantile spasm who do not respond completely to ACTH or vigabatrin. Vigabatrin, if used for more than 6 months, can cause retinal toxicity with the resultant visual field effects despite the withdrawal of the drug. And a word about vaccination during the treatment period. All live vaccines are contraindicated. Other vaccines are not effective during ACTH and steroid therapy due to the immunosuppressive effect. All vaccines are thus not given during the hormonal therapy and in the period following it, usually less than or equal to 3 months after the last dose.
Thank you, Anita. The discussion is primarily on a baby who's actually got infantile spasms, and you have a child who's hypotonic. So, what exactly? I mean, would you kind of localize hypotonia generally as? Whether I mean, can you have a discussion on that, please?
Gray matter disease, sir. Yeah, I'm not sure about your questions. Can you repeat it again?
What I meant to ask is, if there is a baby who's hypotonic or floppy, what is the usual localization that you would like to say? What do you say generally? Anatomical localization. How do you do?
It can be cortical,
Central or
peripheral.
motor unit. Peripheral hypotonia. So, can be either in the brain or brainstem, or it can be in the spinal tract levels and cervical spinal area. Otherwise, it is in the motor unit, where you are looking at either an anterior horn cell disease or a peripheral neuropathy or neuromuscular junction abnormality or somewhere in the muscle. So here you are thinking in terms of a central nervous system problem. That is why because there is this morphology that is also there. What are the other characteristics of central nervous system cause for floppy infants? What are the other physical characteristics that you might get a hint of? Which is probably a central nervous system problem. What is weakness and what is floppiness? What is floppy? How do you say hypotonia? Floppy means hypotonic baby. So how do you think of hypotonia and weakness in there? What is the difference between hypotonia and weakness?
Hypotonia, child will be lying flaccid, flabby.
How do you make out that there is hypotonia in a child?
Child will be having
movement.
And
what are the passive movements? What is the passive movements going to be? Hypotonia increased resistance to passive movement.
Passive range of movements.
So what are the other things that you will get if it is a central nervous system problem that is there in a floppy infant that you can see because a central nervous system problem? Weakness may not be as profound as in a peripheral system. Peripheral weakness will be very much profound. It will be profound weakness in the peripheral system. And accelerated DTRs, like somebody suggested, Supriya suggested that there is going to be accelerated tendon reflexes. That may also be there, yes. Whereas if you are looking at a baby who's got peripheral reasons for hypotonia, the baby may have absent reflexes. Or normal reflexes. Okay. So then, wow. I mean, what are the typical posture that you describe for a baby who's floppy? I mean, അതൊന്നും അതിനകത്ത് വന്നില്ല, ഹിസ്റ്ററിക്കകത്ത് വന്നില്ല. പോസ്റ്ററിങ് വരാം അല്ലേ? Drooling can be there, frog-like posture can be there, generalized positive might be there depending on, there can be a weak cry depending on the etiology. The baby may have paradoxical breathing, and maybe plagiocephaly that is the present. All these things are there, right? So all those things have to be spoken about. I synaptosis under India. There is a cry which is shrill cry, because that is what usually suggests a CNS problem. Whereas if it is a weak cry, then there is a or a feeble cry will make it, if it is a peripheral cause for floppiness. And in mother's examination is also important. It is important that you should look at the mother. You should describe how the mother is, because the mother is also certain things that you might get a hint to the mother. For example, if you have a baby whose mother has certain characteristic features, you may think in terms of congenital myotonic dystrophy and all that. So those things, there might be some grip abnormality in the mother. The mother might be slender, will things like that. Can you stop presenting?
Yes, sir.
Anything else on discussion that
Jacob, Srinivasan sir is there in the group. Did he join? Sir, your comments, sir? Any more persons' comments and questions we will discuss? Anita, in this case, as Jacob discussed, definitely the how to go forward, what are the hard findings? In this case, it's a 5-month-old baby without any antenatal, lateral, postnatal, perinatal insults, showing a regression of milestones. Definitely, overall pattern of the development is not like a static disorder. It's a regression. Multiple domains are equally affected. And it's a little bit early regression. So there was no development even at the earliest of the social smile. So starting very early, no milestones are developed. Two situations, it can be a significant type of a static disorder where no possibility at all of the development, or very severe of the progression. Both the pattern will be overall will be same. In this case, there is no antenatal, natal, perinatal insult. So we consider the other way around. It's a regressive pattern, most probably at that group of disorders. So the hard finding is definitely the type of movement. So whenever you get a movement, you need to define that. Is it an abnormal movement or a seizure? From the description, it seems more like the seizure, myoclonic jerk type of presentation, because sometimes in a progressive disorder, some of the abnormal movements can present, like glutaric acidemia and all. Abnormal movement may be presenting, but it is definitely it's not an abnormal movement, it's a seizure. So 2 points you can catch hold on. One is a regression of milestones, global, and myoclonic seizures. So you can list the conditions with a myoclonic seizure very early. So list of conditions. First one, which we are all familiar, is the West syndrome. The other one, commonest situation is HIE. So HIE sequelae can also lead to any sort of seizure, myoclonic seizure also. But in this case, there is no perinatal insult, so that goes down in the list. Other possibilities, again, intrauterine infections. So these are the situations where the onset can be like that of a static disorder, but myoclonic seizures can occur early. In this case, there are no clues for either intrauterine infection or the HIE. The third possibility, as we rightly considered, was migration disorder, malformations. So in this case, definitely we need to consider the possibility of malformation, because in the general examination, there were some dysmorphism suggestive of a structural problem rather than an intrauterine infection. So that's a clue. The another condition with the myoclonic seizure is, as you said, metabolic problems, out of which phenylketonuria is the classical one. So, in this case, you didn't have any failure to thrive. Comparatively, gain in weight was normal. So, in your the growth assessment, there is a small problem. You said 5-month-old baby, 7.6 is the expected and 5.6 is only there. So, your calculation is so low. Actually, 5.6 is not that bad for a 5-month-old baby.
And for a birth rate of 2.8, your birth rate is 2.8, you said? 2.8.
So, gained comparatively better. That is a point because in a metabolic problem, 2.8 to 5.6, almost double as occur. That's a point against the inborn errors of metabolism also need to be considered. In the inborn of metabolism, not only the global regression, it will be having body growth part also will be affected. And in the head circumference, we need to consider the clues. Neuroregression, one of the classical conditions is Tay-Sachs disease. So in this case, Tay-Sachs, that circumference will be on the higher side. In this case, that circumference a little lower side only. So all these conditions you need to consider. In this case, classical situation is very early onset. Myoclonic seizures from 10th day onwards. So even if you are considering the myoclonic syndrome and all, epileptic encephalopathy like situation, it must be something symptomatic, some underlying problems, then only it will have that sort of an onset. Most of the other idiopathic type of Best syndrome will have an onset usually some 4-month onwards only. You said that 2-month onwards it can occur, but earlier onset is more likely to be something underlying situations. The idiopathic one usually starts a little earlier, and a few of the milestones will be achieved. A few of the milestones like social smile and all will be achieved in most of the cases. In Tay-Sachs also. So initial milestone, then regression will be the classical pattern. Very early onset is suggestive of an underlying malformations, HIE sequelae or intrauterine infections like that. There are not much point for HIE or intrauterine infection. Definitely, dysmorphogenic, the features also suggest that it can be a malformation. So, the presence of malformation and the myoclonic seizure putting together the migration disorder comes in the first few possibilities. Okay, then in the general examination, of course, what you need to stress apart from the dysmorphism, the changes in the hair, the skin, the smell you mentioned. So a little more stress on the markers of the underlying conditions. Inborn metabolism and all, phenylketonuria is a very, very important one. Okay, so hair changes and skin color are important. Neurocotinous markers and other things you mentioned. And in the CNS examination, Jacob sir was pointing out floppy strong and floppy weak. So in this case, you said there is some in the vertical suspension, there was some scissoring or something, a varying tone, even though overall tone was low, but on the vertical suspension, a little bit of flexion at the hip and adduction. Those are Elang sign and other thing. That is arguing for a central hypotonia, and reflux is not absent. Reflux is normal to a little higher reflux. So it's a central hypotonia. So, and whenever you get an hypotonia, you mention about the amylase angle also. Whether it is a central or peripheral, in an age group like that, the amylase angles are also important. That also you need to include in the evaluation. Okay, the other thing that there is nothing much because the MRI is so typical. There is a definite MRI picture and an EEG also. So importance is that West syndrome without any underlying problem, maybe you can get a better response. In this context, the ultimate prognosis is very gloomy. With the migration disorder like this, whatever level of treatment you give, vigabatrin, whatever, it's all a waste because ultimate prognosis will be bad. What you can do is, of course, as Shrija was pointing out, you need to screen the parents and next baby, early diagnosis and genetic counseling is the only thing which you can do. Nothing much to offer for this child. Jacob, over to you. Jacob, any comments from the floor? Any senior persons? Parvati madam is the anybody? എല്ലാവരും തിരക്കിലായി പോയി മീറ്റിംഗിലായതുകൊണ്ടാണല്ലേ ശ്രീനിവാസൻ സാറും ഉണ്ടായില്ല. സിറിൽ എനി കമന്റ്സ്? സിറിൽ ഉണ്ടല്ലോ, എന്തെങ്കിലും ഉണ്ടോ കമന്റ്സ്? Any questions? Anybody having any questions? Discussion points എന്തെങ്കിലും contribute ചെയ്യോ അല്ലെങ്കിൽ anybody? Questions എന്തെങ്കിലും ഉണ്ടെങ്കിൽ പറയൂ. Anita, when you present a list of no ഉണ്ടല്ലോ, no list, അത് കുറച്ചൊന്ന് റെഡ്യൂസ് ചെയ്തിട്ടാണ്, ഒരുപാടാവണ്ട, മനസ്സിലായില്ല? അപ്പൊ അത് കുറച്ചുകൂടി കേസ് പ്രസന്റേഷനകത്ത് അങ്ങനെ ആണ് വേണ്ടത്. ഓക്കെ.
Madam is also there. Madam, എന്തെങ്കിലും പറയാം? Madam is also there, sir. Madam is also there. Madam ഉണ്ട്.
Madam, your comments unmute ചെയ്ത് പറയും. രണ്ട് ഇവന്റ് ഒരുമിച്ചുള്ളത് കൊണ്ടാണ് കുറച്ച് ഇതായിപ്പോയത്. ശ്രീനിവാസൻ സാറും സീനിയേഴ്സും ഒക്കെ കുറച്ച് ഉണ്ടാവാറുണ്ടായിരുന്നു. Any more comments?
Carol, any comments? Carol, sorry.
Any questions or comments? Any discussion points for PGs? Anita, you don't have any other PGs with you? No questions, no doubts, eh? No. Why they are keeping silent? Okay. Okay. There can be many ways the discussion can go like this. The regression disorder, what all neurodegenerative disorders. So we didn't discuss like that because it is fairly typical. In a case like this, when there is a global regression, multiple field, starting very early by that time. So what way you move forward? What is it? It's a white matter type or a gray matter, white matter type, and starting very early. What are the possibilities? So when there's a seizure and a gray matter type of regression, starting somewhere very early, it is the GM2 gangliosidosis, Tay-Sachs comes first. And if it is a white matter type very early, you consider what condition? Krabbe's. Okay. So there are very many questions which are likely in that case. So early markers or CP, how will you differentiate a static disorder CP or isn't because very early onset of a regressive disorder. So Tay-Sachs somewhere around 4 months. Krabbe's white matter, but it will have a typical picture presenting somewhere early itself. So all those conditions will be discussed. In this case, there is no organomegaly. Liver or spleen is not the examination is normal. Okay. Fundus need not have because one of the conditions to be considered if you think the initial milestones are developed, then regression, the gray matter type of degenerative disorders, Tay-Sachs comes in the first in the possibility, and the cherry red spot and the fundal changes need not be there at this age. So how to differentiate a white matter condition from a gray matter condition? And all those will be the points to be discussed in a case of a PG discussion. So nobody is asking any questions, no discussion, then what's the point in this? PGs are keeping silence. അങ്ങനെയാകുമ്പോ ഒരു ഡിസ്കഷനും വരൂല. അങ്ങനെ ആയിപ്പോന്നത് എന്താ അങ്ങനെ ആയിപ്പോന്നത്? നോ പാർട്ടിസിപ്പേഷൻ. PGസേ ഇല്ല എന്നുള്ളതാണ് കാര്യം. തോമസേ, അപ്പൊ അങ്ങനെയാണെങ്കിൽ ആർക്കും താല്പര്യം ഇല്ലെങ്കിൽ പിന്നെ എന്താണ്? ആർക്കും ചോദ്യം ഇല്ലെങ്കിൽ പിന്നെ എന്തിനാ വർത്താനം പറഞ്ഞോണ്ടേ?
ഇത് കുറച്ചാള് കുറവാ സാറേ, പാർട്ടിസിപ്പേഷൻ കുറവാണ് PGs.
പാർട്ടിസിപ്പേഷൻ ഉള്ളതും വയസ്സന്മാർ മാത്രമേ ഉള്ളൂ, PGs ഇല്ല. അപ്പൊ എന്തായാലും പിന്നെ നമുക്ക്
കോട്ടയത്തൊന്നും ആരും കയറിയിട്ടില്ല സാറേ, കോട്ടയത്തൊന്നും PGs ഒന്നും കയറിയിട്ടേ ഇല്ല.
അവർക്ക് തിരക്കുണ്ടോ? KGM-CT ഒന്നും ഇല്ലല്ലോ.
ഇല്ല, കോട്ടയത്തെ പ്രസന്റേഷൻ അല്ലാത്തോണ്ടാന്ന് തോന്നുന്നു. ഇപ്രാവശ്യം പത്തനംതിട്ടന്നല്ലേ.
നോളജിനും അതിർവരം ഇങ്ങനെയൊക്കെയാണ് റീജിയനിലൊക്കെ ആയിക്കോട്ടെ. എന്തായാലും വെൽ പ്രസന്റഡ്, വെൽ ഡിസ്കസ് രണ്ടുപേരും, അനിത സാറും. അപ്പൊ നമുക്ക്
സ്റ്റോപ്പ് ചെയ്യാം സാറേ. ഞാൻ തന്നെ പറഞ്ഞേക്കാം. താങ്ക് യു സാർ, ജേക്കബ് സാർ, അനിത, പുരുഷോത്തമൻ സാർ, and all participants for your presence and participation. Thank you.
അപ്പൊ ശരി എന്നാ. ഓക്കെ, ഗുഡ് നൈറ്റ്.
ശരി, താങ്ക് യു. ഗുഡ് നൈറ്റ്. ജേക്കബ് സാർ, ഗുഡ് നൈറ്റ്.
ഗുഡ് നൈറ്റ്. താങ്ക് യു സോ മച്ച്.
ഗുഡ് നൈറ്റ്.
താങ്ക് യു സോ മച്ച്.
ഇങ്ങനെ ചെയ്യാതിരിക്കുന്നു.